Okay, so now I get to my solution to the ills of the world. Because not long ago I realized that maybe you could actually do something about this. So I started with this thing, iotaMed, which means issue-oriented tiered architecture for medicine. Kind of forced, but it's nice, right? And the idea is this. You remember the whole paper record thing that I talked about? What has happened the last number of years is this, that a lot of people need data from the electronic healthcare record. And what they all do, they invent their own little machines, like, you know, meat grinders, to extract data of all kinds, to have for the registers, for the economics, for automatic diagnosis that never work, and so forth. And what they all do, including the poor doctor, is actually reverse engineer this defective record. The record that only contains what happened over time instead of the actual state of the patient. They all try to reverse engineer that to analyze what actually is wrong with the patient. Right? And there are even systems now in Stockholm, they call it the GTT, where they go through and try to the records where something went wrong, where there was an injury to the patient in healthcare. And they do that by looking for certain trigger words in the text. I mean, that's pathetic, isn't it? Because the information was in the head of the doctor, but he had no place to put it in the record, so it's not there. So they have to reverse engineer the record to find out what the information was in the head of the doctor that never ended up in the record. Right? So instead of fixing the basic problem, because you can't do that because everybody knows how an electronic healthcare record must look like that, so they start doing workarounds. Now imagine for a moment that you could do something about this. They're all looking for gold, right? And the only one that gets really crazy is the GP, who gets absolutely nothing out of all these things. Now, if you did this instead, you collected diagnosis, measurements, therapies, results, follow-up, and so according to a guideline. We have clinical guidelines already, talked about that. And I talked about my extremely positive experience from having to use guidelines, which means I couldn't have done medicine without actually having learned medicine first. But I could do very well modern medicine having known the basic principles of medicine plus current guidelines. If you collect these into a single system, where actually this basic principle, the actual guideline, the diagnosis of the patient, the disease, the therapy, and the place you are in the treatment is collected into the medical record, then you wouldn't need to do the reverse engineering anymore. You would have the actual data. So what I did here was that I called the disease that the patient has an issue. And the reason I called it an issue and not a problem is because quite some time ago there was something called problem-oriented medical records. In the 60s, was it Wade? I don't remember. Who wrote about that. And that failed totally because he was before his time and he didn't do exactly this. They did other things. If you probably learn about SOAP. Have you talked about SOAP? Subjective, objective, assessment, planning, which is often how medical records are subdivided in other countries, not in Scandinavia, but in other countries. That's also from the problem-oriented thing. And where every encounter, every medication should be classified as belonging to a certain disease, it didn't work very well. So I don't want to call it anything with problems, because otherwise they think it's that. It's not. So I call it an issue. Now an issue, and this is the difference, an issue is a guideline for a certain disease, but you can make it into a worksheet, so you start using it interactively in the guideline itself. And you add observations to it. You can imagine it's like having a worksheet in Excel. You start with the template, that's the worksheet, and then you start filling in data. So instead of me going to VIS in Stockholm and looking up how I'm going to treat the cardiac decompensation, I actually make a copy of that guideline, I can start out on paper and just make notes in the edge and save it for the patient, or on screen. I actually write in the guideline what I'm going to do. I'll take away a row and I say, yeah, I excluded this and this is what I'm going to do, and so forth. And then all of a sudden you get something totally different. Forget about the classical electronic healthcare record. Forget about the chronological thing. Work in this. Okay? Interestingly, this is exactly the form that it needs for the national registries, for trial data, and this comes from a presentation I did for a pharmaceutical company. That's why it's so faithful tracking. Yeah. And the GP is going to work directly in these things. Now I'm going to show you how this looks, because I'm actually done a prototype of this thing. At, what do you know, an iPad, of course. So what I did here was actually, I took the text from a clinical guideline, this is in Swedish, but text of clinical guideline for hypertension, high blood pressure. And then in the text itself, where it says typically, you know, you have, this is what I always use for patients. Oh, those are the things I have to check for. When I have hypertension, I go through this. The first time I should do the EKG, I should do the lab results and so forth. But this has no connection today with a healthcare record. So here I put it right in as being the healthcare record. So this patient has hypertension as the record. Now, in that record where it says you should, for a hypertensive patient, check his length with whatever, signs of heart decompensation, sounds of the heart and lungs, examine his stomach and so forth. Then I put in fields so I can enter data directly into it, into the guideline while I'm working. At the same time, I see older values put up here. And for example, for hypertension, you want to have, he certainly doesn't have one now, but you want to see that he has had above a certain level a couple of times in the history. So it's very interesting to see old values with the date next to it, right? So I can put in anything I want here. That's extremely low, but right? See if I can even see the buttons here. Okay, so, and the next time the patient comes, this one has moved over, so it's the past, right? And so forth, work with this. Now, the interesting thing is, it also says, for instance, that these are the lab tests I need to do. And what I do today is I go into this and then I sit there and say, okay, those, and then I do an Alt-Tab to go back to the system, and I go into order this, and then Alt-Tab, yeah, what's, and the patient sits there looking at me and says, what is this guy doing, playing solitaire, what? Yeah. It's so ridiculous. So here, right, I just tap it, and it says order lab tests, and you know, this funny thing. But anyway, the lab tests that get ordered are the ones from the clinical guideline. And now I can go in and check them and say, no, don't do this or do that, and so forth. Right? And I can send it somewhere down here. Except I can't see it really, because this projector screen is too small for me. I have to move it out to see it on this one. Yeah, it's back. Okay. If I go to an examination, for instance, a fundoscopy, that's the, you see, or check the eyes for signs of hypertension and so forth, and I want to do that one, first of all, I would see here when the last was done and grade 1, 2, or 3, which is exactly what I want to have. I don't want to have all the details, just 1, 2, or 3, which means if it's normal or slightly abnormal and so forth. If I do this, he actually fills in the referral automatically. He knows who the patient is. He knows where to send it because it's in the guideline. It says for this region you send these things to that hospital. I don't need to fill in. He actually knows exactly what to fill in as the request as well. Why? Because I went from the guideline. The guideline says do the eye examination for this kind of hypertension, so we can fill it in. The only thing I need to do is send, right? Why? Because the thing knows the context. In current systems, you don't have that. You want to do a referral, it starts out, who do you want to send it to? Why do you want to send? He has no idea what I'm talking about. This one does, because you went through it the right way. Even if you want to do treatments, right? Medication, here it would start out with a recommended medication. Instead of what happens today is, if I don't look in the guidelines, it's like, diuretics, yeah, that's a good idea. Which one can I think of? Okay, Lasix, I used that yesterday. Which one can I think of today? That's how it works. Eh? The one that pops up in your mind, that's the one you use. Here, it would go the logical way. This is a guideline for hypertension. First choice in hypertension, if he doesn't already have it. If he already has it, it would say next to it here, running prescriptions. I know, okay, well, but he needs one more because his pressure is too high. Not that, that's okay. But his pressure was still too high. I say, second choice, I take that one. I go into that, then I actually get, if I'm lucky, slowly, I get a choice of the groups that belong to whatever I chose there, and then I go down and I get exactly the product, and then it's up to the pharmacy to choose the brand. Or I could choose the brand here. And the idea is here to have the tablets and the dosage. Now the interesting thing here is, since I start from the clinical guideline, I already know what disease we're talking about. I know what product I'm going to do. But I also know what dosage I'm going to do. Because if you take antibiotics, for instance, in children, for ear infections, throat infections, pulmonary infections, those are different dosage tables. They have that problem in Stockholm now at Astrid Lindgren's Children's Hospital, where they overdose or underdose children. So they made this extremely complicated system, which is trying to find out from the records what's wrong with the patient, with doses, how big they are, blah, 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 blah. And they sort of succeeded and even got a prize for it. In this, it's a trivial problem. Because if you start from a care program for ear infections, the dosage you're going to get here is for ear infections for a child, because it's a child, and so forth and so on. So the dose table thing, the dose security thing is solved. Even better, if you have a dosage that you have to adjust for liver and kidney insufficiency, right? Can't be done in current systems. You have to know this, and you usually don't, so you do stupid things. Here, if there is another issue here that says renal failure, the system automatically knows this product has a problem with renal failure. Maybe he can't calculate exactly the dose, but he will tell you, hey, wait, renal failure is contraindication for this product. That's impossible in current systems.